Well, it has been about 20 years for me to be involved in this radiation treatment. Lung cancer and breast cancer are my specialty. As a radiation oncologist, actually the breast cancer and the lung cancer are very different when it comes to the AE and the outcomes. The patients with lung cancer, actually, I think they do not complain much, but relatively, patients with the breast cancer, when they have the radiotherapy, they complain a bit more. So it was quite difficult for me to respond to the breast cancer patient when they have to go through the radiotherapy, because there is no one who teach me how to handle this. I tried to learn at field. However, it's quite different from one clinician to another. So I asked one of my senior colleagues, and he said there was a very clear answer to that concern. You just take it easy and you just take it as it is. Let's say you have the rash on your skin after the radiotherapy, or if you raise your hand after the radiotherapy, you feel very strong pain, or you have a hot flashes after the radiotherapy, you have sleep disorder after the radiotherapy. So there are many complaints and concerns from the patient. Then you can say you just take it as it is. It seems to be quite okay to say that, and it seems to be quite okay for the patients to have that response. However, I started to feel that this is not always the right way. So I try to understand how I can address the patient's complaints and patient's concerns. So today I'd like to share what I think about the complications in the radiation treatment. There are many different standards to classify the complications after RT, depending on the dose, or depending on the extent, or depending on the severity, or depending on the areas where the complication occur. And some complications are overlapping, but as you can see on the slide, there can be many different complications occur after the RT or during the RT. Some, it's not like the radiation oncologist just to go on with the treatment if these complications are so severe and life-threatening. Most of them are very mild, and sometimes we do have some severe ones, but the risk or possibility of having such a severe complication is very low. So compared to the benefit of the radiotherapy, such a risk the risk is not that high. So my topic today is how we manage the complications from the radiation treatment. However, I want to become the radiation oncologist who, from the very beginning, not cause complications. However, still, as introduced by two speakers, the benefit from the treatment outweigh the disadvantages, such as complications. So we need to be more wise when it comes to receiving and doing the radiation treatment and managing the complications. For example, we can have the radiation dermatitis, breast edema, pain, and fatigue and distress that can occur during RT, and immediately after the RT, there can be some radiation pneumonitis or chest wall pain. And after RT, for quite a long term, there can be lymphedema although it's quite rare, sometimes the cardiovascular complications can occur. And of course, there are some special considerations which include pregnancy, lactation, breast reconstruction, and second malignancies. For radiation dermatitis, as Dr. Hye-young Kim introduced, actually it's something that most of the patients experience. If there is no change to the irradiated skin, then we, the radiation oncologists, might be very much surprised, and we will be concerned because maybe radiation is being irradiated into other areas, because dermatitis is something that always happens. But there can be some differences in terms of the grade or the severity. Think about when you were young, you are playing outside for a whole day, and some of your friends have burn on their skin, but after 1 or 2 days, many of them are fine, but some friends still have some issues. So like after 1 or 2 days from the RT, some patients ask, why don't I have the dermatitis? But anyway, 1 or 2 weeks after the RT, usually dermatitis starts. And when it comes to the treatment, it's about 4 weeks time period for the RT. So during the RT, patients do not feel the dermatitis, but after the RT, 1 or 2 weeks after that, they feel the itchiness or irritated area. And there are different grades. Grade 1 is faint erythema. And second grade would be wide-ranging redness on skin. Like 20 years ago, most of the patients after the RT, they have irritated skin, very wide area. But now it is not the case. Usually, the grade 3 or grade 4's radiation dermatitis are not easy to find. Smoking or skin exposure, large skin exposure, increase the risk of the radiation dermatitis. And if the patients take the treatment or drugs because of the rheumatitis, they need to consult with the doctors, like the scleroderma, although there is a not strong relevancy, sometimes because of the radiation, rheumatitis can be worsened. So patients with such underlying disease or the conditions need to consult with doctors about those issues. And if there is chemotherapy done concurrently, although it is not quite common, if the patients have the surgery and then radiotherapy, sometimes they have the oral chemo drugs. If that is the case, the dermatitis can be worsened, but that's not that much serious to the extent that we delay the RT. So what we can do about it? We just do RT well. That's the best way. Like the nipples or the lower part of the breast, the protruding areas are the ones where the dermatitis develop more than others. So for the IDRT, the sophisticated ones can be utilized in order to have evenly distributed irradiation over the place, over the area. And during the treatment period, try not to have irritant on the skins. And you can use water-based moisturizer and reduce the skin irritants. Like for the moisturizer, 2 to 3 times per day, you can use it. There is one more reason for using this kind of a moisturizer. Of course, we do it in order to reduce the damage, but at the same time, by applying the moisturizer, you can see the area under treatment. So you can check if there is any dermatitis or not. Sometimes patients even do not look at the treated area. So by applying the moisturizer to the treated area, patients can actually see the area under treatment. If it is serious, the steroid can be applied. Some people do not like it. However, it's better to use steroid ointment rather than just scratching on the itching area. It reduces the secondary damage. Of course, the oral drugs also help. And of course, you do not use gauze. Rather, you use Mediform hydrogel hydrochloride to the irritated area. It helps restoration of the damaged area. And if the infection is serious, then we can use antibiotics. And for the breast edema and pain, it can take place after the surgery, not just after the radiotherapy. The breast pain need to be well studied, meaning that right after the surgery, the breasts are numbed, and when the senses are coming back, you feel some pain on the area. So it's important to distinguish whether the breast edema and pain are coming from the surgery or from the RT. And radiation itself can affect the chest or the bones in the chest, increasing some pain. And the chemo, the patient who had a chemo also can have some breast edema or pain. And when you have breast edema or pain, you can apply ice pack. Some patients who are admitted to the nursing homes or who are taken care by the not well knowledgeable caregivers, they usually apply not ice pack but hot packs. That's not good. And gentle massage over the breast would help you because it will help the circulation at node. And if the pain is too strong, then it's better to take analgesics. Sometimes the muscles are the muscles are atrophical, and that makes the situation worse. So it's better to take painkillers before it gets serious. And you can have the ice pack, or you can even use the ice packs that you can get from the fresh food delivery. And fatigue, cancer-related fatigue. That's very subjective sense. Physical, emotional, and cognitive helplessness and exhaustion. That's cancer-related fatigue. You just cannot do even a very small and not difficult daily routine after the RT. As if you're having muscle pain after when you have cold. Although the RT is done on breast only, The radiation can cause other symptoms in other areas. But when it comes to the fatigue, when you have the anti-hormone therapy or chemotherapy or targeted therapy, it can also cause fatigue. And there are other conditions that can affect the fatigue, like anemia or hypothyroidism. For example, tamoxifen can cause systemic symptoms like this, and like erythema and fatigue. And blue bar is my part, radiation therapy. And under radiation therapy, other therapies can also influence the patients under radiation therapy. There can be acute effect from the chemo, but at the same time, there can be subacute effect of chemo that peaks during the radiation therapy, such as fatigue. And that's kind of a subacute or delayed effect of chemo. And anti-hormone treatment is done after the surgery, like tamoxifen can cause fatigue. That can be overlapping with the period of the RT. So what can we do about fatigue? There is no clear solution to that. There are many things discussed among the experts. However, there can be no one solution. But experts say that we need to understand it, meaning that it's not just about RT, but also anti-hormonal therapy, chemo can cause fatigue. Sometimes patients feel exhausted when they see the face of doctor or even the gate of the hospital. So it's a quite subjective feeling. So you have to accept it and recognize it. And you have to clearly understand that feeling fatigue does not mean the progression of disease. And exercise, the physical activity and exercise is important. And have some support or help from the experts. And the American Cancer Society also talks about cancer-related side effects. It mentions like the cancer-related stress. Here there are many side effects that are related to the psychological stress. And the cancer-related distress here is something that should be understood, meaning that it's quite natural for us to have stress because we are treating the cancer. So when we make treatment choices, if we are too much stressed, then it will negatively affect us. And when we have other risk factors like we are old or we're too young or I do not have a husband, I do not have a wife. So these other factors also put patients with more distress. So for the treatment, you can have some help from the faith group, or you can have some support from the social workers or mental health providers. And it's really important to have the social network in our daily lives. But as if we are taking pills when we have cold, when we have strong stress, and when we are seriously distressed, it's quite natural for us to see the mental health providers and to have the prescribed drugs to treat my health condition. And what about the radiation pneumonitis? I said it is quite rare. It's lesser than 1%. And if we just treat breast only, then the rate is much lower. And it starts right after the RT and sustained up to 6 months. Symptoms include dry cough and shortness of breath. Sometimes the patients say, well, I had dry cough in the past. So they get better and then share the symptoms. That means it was not that much serious. Of course, steroid can be used in serious cases. There were not many patients who worried about RT in the past, but now I see in the clinical setting is that they are worried more about the radiation pneumonitis than before. And why is that so? I think it's because of the COVID-19. Like, let's say you have cough at the 3 months after RT. And you see that the breast here and supraclavicular area, then you have some marks in the CT of the lung. Then after 2 years, the RT marks are gone. So people now worried more about the cough. And if they look at their X-ray image, now they are not able to have the treatment because they have to have the COVID-19 screening test until they have the negative result. So when they see the X-ray, when they see this kind of atypical structures, you need to understand this is not that serious and the treatment can be very effective. For lymph edema, I think the rehabilitation specialists are in the better position to explain well. But what I want to say to the patient is that RT takes about like 4 weeks or 6 weeks, and every day patients have to come to the hospital. And in order to reduce the lymph edema, we need to reduce the extent of the treatment, and also we need to refer the patients to the rehab specialist. It's important. While you visit the hospital every day, you go to the rehab department and you learn how to massage and how to stretch. And you need to learn how to manage lymph edema later on. So these are the contents that you can see. Now, what about the radiation-induced cardiac toxicity? Usually, there can be an increased risk of the coronary event. It says 7.4% here. It means 7. It does not mean that 7 out of 100 get the disease. It does not mean that. Of course, the radiation is irradiated to the area like the heart, the breast. And in that case, we can reduce the possibility by utilizing the positions, but by doing so, we can reduce the risk of angina. But you don't have to be too much worried about it. And there are also reports about the radiation-induced carcinogenesis. This is one page from the textbook on the radiation oncology. Radiation is not something falling from the sky. What I mean here is that radiation may increase the already existing genetic mutation risk. There has been a lot of studies on the radiation-induced carcinogenesis, although it says 8% of excess risk, but it does not mean that 8% out of 100 can have radiation-induced carcinogenesis. Out of 150,000, 12,000 persons may have the excess risk of second cancer. So let's say we have 1,000 persons. After 10 years and 15 years, about 5 persons may have the second cancer. But if you think about the survival from the breast cancer treatment, then you can see the benefit of radiation treatment much outweigh the risk. Because of the time constraint, I will skip this part. So for pregnancy, RT is prohibited, particularly in the early term. And it's recommended not to be pregnant until 1 year after the RT. After the breast cancer and after the RT, if the patient is get pregnant, that does not affect the long-term survival. And after the RT, lactation may be a bit difficult, although it is possible. And after the breast reconstruction and RT, you may have capsular contracture. So when we have the breast reconstruction for the patients who have to have the RT, then autologous skin or the autologous tissue can be used. Here you can see the picture of the capsular contracture, and you see some skin or the lipid fibrosis and necrosis. The hardened part, however, may not be the recurrence. It may be the hardened adipose tissue. So patients under RT, as I said, they visit hospital every day for some weeks. So I see them quite a lot. And many times patients blame others, like saying that my husband has been so bad and my son has been so bad. They put a lot of stress on me, and that's why I have breast cancer. So when I have such patients, I say that it's not like you are having this cancer because you're not good. You have been living such a good life and you have been doing quite fine. So you just keep going on. And you can have a disease of a certain part of your body, but you can fix it. There are benefits of RT. Of course, there are side effects of RT. However, the side effects are not that serious and not that much.